Telehealth adoption skyrocketed over the last year, one silver lining from the pandemic. This trajectory is indicative of the larger transformation in healthcare delivery. Healthcare systems are moving from a long-standing brick-and-mortar model to virtual care. Nathan Ray, the Director of Healthcare and Life Sciences at West Monroe, will moderate this panel of esteemed panelists about what lies ahead for telehealth and high-quality clinical care. Nathan, please take it away.
Thanks, Maria. Welcome, Linda, Judd, Richard, and Carrie. This will be a fun conversation, and we've got quite a few of you here, so let's get started. Maybe a quick one to get everyone talking. How has telehealth changed or challenged the footprint of your organization over the last year? Richard, you mind starting us off?
Sure. It's really exciting what we've seen through the pandemic. I mean, first of all, never waste a good crisis, right? But the pandemic really drove us into leveraging technology. And it accelerated all the work that we had been doing in Kaiser Permanente in the 2 decades preceding COVID-19. So in Northern California, we rapidly scaled up and conducted nearly 4 million video visits with our patients over a 10-month period in 2020, compared to only 100,000 video visits in all of 2019 combined. So at the peak, we were doing about 82% of all of our ambulatory care visits via video, as compared to 15% prior to the COVID-19 pandemic. Now we're doing about 50%, but I think what the COVID-19 has taught us is that patients embrace this technology, and so do our physicians and our staff. And I think the future is incredibly bright for the integration of technology into care delivery.
Thanks, Judd. How has your organization kind of weathered the last year and the challenges of telehealth?
I think I could almost say ditto to Richard's. We have one big disadvantage compared to Kaiser in that we have to rely on external payers. We don't own the insurance plan as well. So we have been challenged in pre-COVID by reimbursement models and anticipate the same challenges coming back post-COVID. But when everybody paid for this early on in COVID, it was easy. We celebrated, we don't have as big a reach. At Jefferson, we have we'll be up to 18 hospitals soon. So still a reasonably large health system in Pennsylvania and New Jersey. But we celebrated, and my team joked it was Judd's wedding, a big celebration when we did our 100,000th visit pre-COVID over 4 years. And then that became, every 4 weeks we were doing 100,000 visits. So we, like Richard, we peaked at about 90% of visits overall. We've come back down to about 20% of our ambulatory visits, but with huge variability. Our behavioral health program, which wasn't really engaged, even though many others were, is now doing basically 100% of their visits, unless you need a long-acting injectable medication via telehealth. Our trauma service is under 1%. Our surgical subspecialties vary between 1 and 63%. So I'm sure, like Carrie and Linda will tell you, there's variable adoption across the organizations in different specialties and different physicians, but it is clearly here to stay. It is loved by patients.
Carrie or Linda, how has UCSF or Intermountain looked at telehealth in the last year?
Well, at Intermountain, we started our telehealth department in 2013, and so we certainly had a running start to telehealth prior to the COVID coronavirus. I feel like I'm halfway between Judd and Richard because Intermountain's an integrated health system. We actually own an insurance product as well as 24 hospitals and 180 clinics. I am in charge of the direct-to-consumer side, and I laugh jokingly that prior to Rudy Gobert and the entire Utah Jazz bringing COVID back to Utah, I was struggling to get 10 virtual visits a week out of my direct-to-consumer outpatient department. Within the first weeks of us having our first cases of coronavirus in Utah, we then began averaging about 7,000. So we went from 10 virtual visits to 7,000 virtual visits in a period of about 2 weeks, and had projected to have about 1 million overall interactions, telehealth interactions from Intermountain. We actually surpassed that. We did close to 2.8 million interactions between our acute and outpatient services last year.
Wow.
Yeah, same for us. We started our program. So we're just an academic medical system. We have 4 hospitals in the San Francisco Bay Area and a fairly extensive affiliate program. The telehealth program started in 2015. So we did have a running start like Carrie did. We had in January of 2020, we had reached the point where we had pretty much every ambulatory clinic had 1 or 2 providers who were doing some amount of telehealth, and that all added up to about 3,600 visits in all of February and about 2.5% of total ambulatory care. And then COVID came and we just turned up the volume on everything that was already happening. And by April, we were doing 15 or 16 times that per month. But I think we really benefited from the fact that there was, like, everybody already knew somebody who was doing telehealth. And I think that really helped us ramp up fast.
Gotcha. Follow on for you, Linda. What is the impact of telehealth? Obviously, it allowed us during the pandemic to access care differently. But when you think about your care model, or when you think about quality within your organization, how is telehealth a part of that?
Yeah, we definitely have feedback from patients that they are incredibly grateful for the service, for the availability of it. Every single doctor has a story of a patient just starting the video visit, expressing their gratitude for not, remember, we're a quaternary tertiary medical center. People drive from far away to see us, and they're so grateful, to not have to do that. We're also seeing significant changes in the way that we use our physical space. Right now, for a while, that was we did so much telehealth that we were actually able to maintain required physical distancing in the clinics. And as those requirements go away, we're gonna look at real significant changes in terms of space utilization, and then also workforce utilization among not just physicians but also clinic staff.
Can I add to Linda's comments there on the space utilization? Because this is something that really plagues me. Particularly in the Northeast, where we don't know what's going to happen with our reimbursement model, and people keep kicking the can down the road a couple months. It turns out, unlike my kid's apartment, you can't do a month-to-month lease on an office building. So as we have leases come up, it would be really nice if we knew what the reimbursement landscape is, because the payers will say, you don't need bricks and mortar to do it. We should pay you less. And that would be true if I knew they were going to pay us and I could shed some of the bricks and mortar leases. But this living in no person's land where they keep kicking the can down the road, it's really difficult. But we think about it exactly the same way Linda does. We just have our hands tied and can't move.
Yeah, and I think I'll jump in and say, from the start of your question, I look at it as an eternal mission of equating access and telehealth. And so whenever I'm in a meeting and they're discussing access for our patients, especially our rural and frontier patients, the first question I ask is, what are you doing with telehealth? And I oftentimes get blank stares from some of the service lines saying, well, we didn't know we could do that. And as Judd says, we don't know if we can do that. But what telehealth does allow us is the opportunity to reach patients and provide care to people wherever they are, whenever they need it, if we can get paid for it.
Yeah, I agree with what Carrie's saying. What we've learned is that technology can rapidly move wisdom and expertise to drive quality and care without delay. And I'm very fortunate at Kaiser Permanente system, integrated care and coverage like Intermountain Health. We're capable of providing seamless care. So, and we've been doing this for 20 years now in teledermatology, for example, because our dermatologists love to provide in the moment consultations. So if in a primary care office, there's a lesion that raises question, we're able to bring a dermatologist in the moment to recommend a treatment or an appointment for evaluation and ultimate biopsy. And I think, as I said earlier, the COVID-19 has really accelerated that. And now all of our specialists are trying to determine where is the greatest value add with video. And I think that's what the nation is going to be challenged with. In a fee-for-service setting, we want to ensure that we're creating value and not just another element for revenue generation. It's really about where do we create the value and drive the ultimate highest quality, care without delay, and efficiency.
As you execute the kind of development of your models, have you noticed the kind of engagement and experience expectations of your patients to evolve? And have you found any limitations, either from your organization or from your technology or from other areas in being able to fulfill those expectations?
So we've had a fabulous experience just tracking what happens with our older patients. We have in the thick of COVID, in California and like in most states, it's perfectly fine for a patient to decline a video visit, right? They are offered an in-person visit instead. That's the law, and also sort of aligned with patient-centered care. But as the pandemic wore on, patients who would normally decline a video visit really needed to be seen. So we started to reach out to them. To just a very friendly person would reach out and call them and make sure that they were set up in advance to do their video visit. They were very responsive, and we're at the point now where we still offer that service, but often like the people, they don't need the help. They get it. They got it. They're fine, right? They don't really need our assistance. But at the same time, we've also discovered that there are the people who, with even a small amount of hearing loss, often age-related, can have difficulty hearing from devices in a way that they wouldn't hear in the office, right? So we've had to sort of jump really quickly to look at technologies to support that. And without sort of the enormous level of utilization, I'm not sure that need would have risen to be on our radar, right, the way it has.
And it's interesting, Linda, I actually had a provider reach out to me, an aging provider who was asking about using one of the echo stethoscopes so that he could enhance his own ability to hear patients and stay in practice. And I said, absolutely, we can do that. And I agree with you. I've noticed the same thing. In the 15 years that I've been working in telehealth, there's this mythology associated with the fact that as a patient ages, they're less likely to want to be engaged in telehealth. And I don't find that to be true. I think it's more about how you interact with a patient via telehealth and the ease at which you make support services. Like Linda said, we have a similar program where we can do what's a tech check with the patient to make sure that they are getting the resource that they want to get. I think for me, again, because I have a lot of rural and frontier populations, it's that ability to either have cellular strength or bandwidth in a community that is otherwise pretty limited.
Yeah, I'll add to what you're saying is because we don't talk about this a lot, but you probably all do it. It's not just about the patient, right? It's the patient and the family. So, in Kerry, in your neck of the woods, or Linda, yours, or, all of us, really, it's probably easy for a family member to go to 80-year-old grandpa's house and work the tablet for them than to go to 80-year-old grandpa's house and drive them 100 miles to the hospital. So, we think about, oh, that's my patient, they can't do it. That doesn't mean it can't be done for them. And so we actually think of everything as patients, families, and caregivers. And there's almost always someone who could help out that makes it easier on the whole care team than bringing them down to the hospital.
Yeah, I agree with what Judd is saying. We do all of our initial hematology oncology consults via video. The first consult is done in the comfort of the patient's home with all of their family members present. And with the electronic medical record, we're able to have a much more robust conversation and talk to the people that are important to the patient in the process. I think personalization with the implementation of technology is critical. And for the last 15 years, my organization, when we implemented Epic, we opened up as a benefit the opportunity to secure message or email your physician. And that's created a lot of downstream efficiencies. Once again, in an integrated care and coverage model, we are able to evaluate the patient or order the appropriate tests prior to a visit which just ultimately decreases the face-to-face contact. And what we're finding is, particularly in COVID-19, the most trusted name is the patient's personal physician.
Yeah, and Richard, I think you bring up a great point about that home and family environment. The one thing that we get, or one of the benefits that we get from a telehealth visit over an audio visit, is you really get to peer into the social determinants of health of that patient. And so you're able to look at the patient's body habitus in particular, but also their surroundings. You can take a patient to their medicine cabinet and do a true medication reconciliation that includes over-the-counter meds, and more often than not expired meds, but also meet the family members and not make assumptions. I think of a story that came up with our COVID mini kits this year, that we had a patient sent home from the hospital, an 84-year-old patient, to home with the COVID mini kit, and she was doing great with it. The problem was nobody thought to ask if there was anybody else in the household, because she was normally cared for by her 54-year-old daughter, who happened to be in the ICU with coronavirus. So if, that through our video interaction, we were able to find out she was home alone and really didn't have the resources that was thought to have had when she left the ED.
And the video interaction, social determinants, med reconciliation is great. But in the on-demand world, where I actually serve as a doc, it's kind of like wilderness medicine sometimes. Somebody calls and they need a splint. They don't need to go to the ER for 5 hours. And you're rummaging around the house saying what could serve as a splint. And it might be a shoebox. It might be a ruler. And you know what? It keeps them out of an ER on a Monday night that they don't need, because they could be splinted and go see the specialist on Tuesday or go to the urgent care on Tuesday, depending on what's needed.
I have ordered many a cribbage board, Judd.
Yes.
They make great forearm splints.
There you go.
We've also had lots of examples of patients who are, when they're seen in the clinic, it's after they've been made sicker by travel, right? We have a pediatric headache clinic where kids are made iller by long car rides and sunlight. And then, a 3-hour ride in a wheelchair van to see your ALS neurologist, right, is a really difficult thing. Yeah. So we have doctors reporting that they just see a completely different side of their patients. They're more interactive. They get more clinical information from their interview, benefits that we didn't really think of when we started this.
As we've all adapted, and, I personally had only virtual care encounters for the majority of this year. I guess the thing I don't have a great perspective on is, what are the accommodations that providers have been making on the other side of the Zoom conference? Have there been, any challenges to their ability to provide care, or just acceptance of the way you're providing tools to assist in telehealth?
So I'll take that, and I think it varies from things like website manner, where all of us have something that's reasonable in the background, and my fan isn't spinning. And actually, just this week, after a year, we rearranged the room so you can't see the bed behind me, because it's a bedroom and this is a nicer view. And I have a series when I give talks of the window behind me being open or closed to varying degrees, where I could look like the angel of death and just be an amorphous black shadow on a really sunny day. So there's things like that. And then we're in a really interesting spot, and you're talking to, a team of people on this panel that have all done this pre-COVID, but there are no people coming out of medical school who knew how to do telemedicine. There are no mid-career physicians who knew how to do telemedicine. And there were no end-of-career physicians who knew how to do telemedicine. So training the group of physicians when they couldn't look to seniors and they hadn't learned it before was actually a big challenge. And so I think that's what providers needed most. But the second thing they needed most was at least knowing how to troubleshoot little technical issues. And there's no doctor in the world that aspired to be an IT support staff. So that's tough.
I agree completely, Judd. And I also, usually when I'm speaking to new providers who haven't used telehealth before, remember to say, use common sense. you treat your telehealth visit as you would your exam room. I wouldn't walk into the exam room eating a sandwich and carrying my Diet Coke with me. Sometimes I'd want to, but I wouldn't do that. We have gotten more lenient about barking dogs and children crawling on laps and that, but wherever possible to put some guardrails on your environment, especially with patients that you don't have a relationship with, and try to remain professional. Like Jed said, we do teach a program to all of our telehealth providers. But prior to COVID, you're absolutely right, Jed. We're kind of like those geeks in high school or Dungeons and Dragon people that loved telehealth before COVID. Now everybody gets what we like to do, but there weren't a lot of us out there, and there weren't a lot of people to mentor others.
I agree with Carrie. We have a telehealth etiquette. If you normally would be wearing your white coat during the examination, even though you're at a remote site, we expect you to, look the part. And I think that brings this level of credibility and professionalism into the video. And to Judd's point, early on, people got experience, and they were in their own settings, and they didn't have ring lights in front of them, and they might have had their kid open the refrigerator while they were having a private conversation. It's really common sense. I totally agree with Carrie. You want to ensure that it's a professional environment, it's quiet, and that there's eye contact, and that the physician is actually listening and explains exactly what's happening during this new type of experience for patients.
Yeah, I concur with all of that. One of the areas where I think we've seen, where I'm just so grateful for the way our faculty have responded, is the way every subspecialty and subspecialty has really had to set their own guidelines for, like, what is a telehealth appointment? When is a video visit appropriate? And then how does that change as the state of the pandemic has changed, right? As the sort of risks of going out have waxed and waned. And there is enormous variation between specialties and subspecialties. As you might imagine, we definitely have many new patient first appointments in some specialties are via video. And it's enormous variation, and it requires just a lot of communication among colleagues, right, for a clinic to settle on a set of guidelines.
Thanks. When you look at kind of the market, and I think telehealth has been probably the most common term, but there's virtual care, there's a number of other, I think, words that are out there in the space. Is there kind of a common definition of what you think encompasses your telehealth strategy? And, are there expansions? Is remote patient monitoring, on the horizon? Are these things all aspects of a new care delivery model that you're putting together? Or is telehealth, for all intents and purposes, just a virtual encounter? And is there kind of an evolution in how your organization is thinking about that growth?
Well, I think there's a huge opportunity. I'll take this one first. When you think about convenience and access, telehealth is on the forefront. It's incredible. But it also allows us to move expertise and wisdom to any patient setting. So we've been using telestroke, for example, to bring the neurologist to any one of our 21 hospitals instantaneously to provide care without delay, so that we can initiate the appropriate treatment thrombolytics with record-setting or industry-leading door to needle time. And you can see how that can play out in almost every single specialty, where care without delay drives tremendous quality. We have telecritical care set up here in Northern California, where I have critical care physicians that are monitoring via telemedicine the patients that are in our ICUs. We're able to use an advanced alert monitoring technique. Before the patient has a deterioration, we're able to initiate a rapid response team to the bedside to help prevent a catastrophic decline in health and ultimate code. So I think that there's the telehealth for personalization of care and convenience, but there's also the telehealth that moves expertise, drives very high quality in all of our settings.
And I think it's how you get creative doing it. So I think, clearly in my mind, you should count everything: asynchronous care, audio, video care, email, all kinds of things we don't get paid for. But the question is, how can you deliver really great care? So we're also on Epic like Richard is, and we were doing e-visits, and our primary care providers, they don't work weekends. They may not work clinically for a couple days. So we had a 24 to 48 to 72 hour turnaround. So who does work all the time? Our seamless access nurses who make appointments. So we centralized who handles the e-visit. If there's a question, they can either kick it out to a core group of doctors who will be available, and someone is on 24/7, 365. We're now down to a 2 to 3 hour turnaround time on our e-visits. And if we need the primary provider engaged, we could direct them over there, or we could escalate it by appointments. So I think when you just put the hat on and say, how can we do this fast? How can we do it better? How can we take care of patients? I would advocate everything that's remote includes seeing the patient. It includes telemedicine.
Yeah, and I made the comment yesterday that everyone laughed at, but I said telehealth in general is becoming very incestuous within our world. We actually have a virtual hospital, and as Richard pointed out with Kaiser, we have a very robust telecritical care, telestroke, newborn resuscitation, telehospitalists. And we reach not only our 24 hospitals, but about 48 other hospitals in our 8-state footprint that we provide 24/7 eyes on glass care to their patients. I run the direct-to-consumer side, and there's a lot of bleed over there. And so what we've now done is our remote patient monitoring has gone on steroids thanks to coronavirus. But we're also seeing that we've got to make the connections between that acute care and the remote patient monitoring side, maybe even starting that monitoring as part of acute care and following the patient through a post-acute arena. I'm working with computer vision products. And actually, I find myself more and more now when I speak to varying vendors saying, okay, we've already have the microphone and the speakers in the room. I don't need you to replicate that for me. I need you to bolt onto the services we have. And so we're really kind of Frankenstein creating a bigger version of what telehealth is. It's not siloed like here's our PM, here's telehealth and the in-room services. Here's this. We're really trying to make everything meld together and work together. And it's really fun and fascinating.
Well, on that, have you found any, again, specialties or areas within kind of your kind of multi-dimensional care model that have not weathered the move to telehealth well, that are still struggling to utilize?
Oh, absolutely. Yeah, but that's because they don't want to think outside the box. It's not that it can't be done. I have 4 questions that my staff knows to ask. And normally somebody will say, can we do it? And my answer is always, should we do it? And then how do we do it? And then finally, why did we do it? And there's a lot of people who can't build the plane as you fly it. And much of this dimensional thinking is beyond folks. It doesn't mean that they won't come back. I have several service lines that are now very actively pursuing telehealth programs that kept me at arm's length for a couple of years because they couldn't see the ability or impact. And coronavirus helped us with that. Now it's about how do we get this? And then more importantly, from my aspect, is helping them hone down what are you trying to do with telehealth? Because there's this large, it's like having a Costco size of opportunities that we can offer them, but really getting them started with what are your needs? What are your needs that you're trying to meet? What are your end goals? And let's start there, and then we can grow from there into this much larger thing. But let's meet your initial quality outcome measures or whatever it is that you want to do.
I want to add a friendly amendment to your question, Nate, but give the exact same answer Carrie did, which is it's not about which specialties, it's about which people. Because, as Richard said, all their hematology appointments are by telemedicine on the first visit. Well, we may not have a lot of hematology adoption, but it's really about the people who are the hematologists. Because at the end of the day, and you used the term yourself, Nate, this is just a different care delivery model. And people just need to utilize it when it's appropriate. And all too often we have conversations where a listener listening to this panel could actually erroneously think we're saying you either get telemedicine or in-person care. You just get care, and sometimes it's telemedicine, sometimes it's a phone call, sometimes it's email, sometimes it's in-person care. It's just one delivery model to take care of the whole of the person over time. And then it's the people who are the physicians and the patients who determine which modality are they afraid of and which modality do they like better.
And there are just some specialties that don't lend themselves, right? Radiation oncology, right? Ophthalmology, right? Which that like the extremely small percentages of video visits in those areas for us. You know, there isn't a slit lamp camera on my iPhone, right?
So we do ophtho actually. See, that's the interesting thing. We have somebody who wrote a K award who runs we have Will's Eye, which is a dedicated, it might be the only 24-hour eye emergency department, and they get transfers, and a decent percentage of their transfers don't need to come. So they are getting more and more aggressive in using telemedicine to streamline the transfers. So again, it depends who you are and where you are as to how you embrace it. And they don't have a slit lamp either, but you know what? It looks and sounds like conjunctivitis. There's no reason to think it's anything else. You don't need to put them in a helicopter and fly them in.
Well, and along that path, we could solve diabetic retinopathy screening worldwide with telehealth. Nobody needs to go to a center to get diabetic retinopathy screening. We have the devices available that could be in every primary care office in the country. We just have to have the payment methodology. I point to Judd, who's on my side in this video screen. But yeah, we have to have the reimbursement methodologies available. And the technology is becoming quite affordable now for that to be a reality.
You mentioned devices and other things. Have you seen an uptick in the data you're collecting, or an improvement in the ability to use data since everyone's interacting systematically?
Absolutely. We have, as part of coronavirus, it was planned ahead, but we utilized a good pandemic for good. We created a 24/7, what we call monitoring center. It was initially going to be the remote patient monitoring center, but it is now the monitoring center, and all biometric data or all patient reported outcomes that are associated with telehealth come through that monitoring center, and we're able to do analysis and analytics on that. And the devices just, if wait a day, there's 10 new devices available. So it's really about finding the device that best matches the needs and ideally is most effective. But there is a secondary challenge to that of, remember, when the data comes in, if you integrate it, you're responsible for it. So you can't just say, I want this data, because you've got to be able to not only analyze the data, but you have to have a pathway to manage that data and respond to it as well.
Gotcha. And this question, the answer may be, and in fact, I assume it's you, but as kind of experiences and technology and services are all being designed, do you think of telehealth as like a product of your organization? Is it something that you're, possessing and iterating, almost like,
we consider it a support service like IT.
Yeah. But we also do iterate and constantly improve like a product.
And it is something that you or a group of people own the vision of, or is it something that kind of evolves through committee?
Both. We have our telehealth and outreach team, who I lovingly call Thor. But each of our programs within telehealth have a strategic governance committee, and we make sure that we interact with the system and all system players as a whole in that.
Richard, when you look at the market, who do you think is doing it best? Who is worth following? Who do you see as innovating within the wider field of play?
So that's a great question, Nathan. I think when you look at the digital front door, I mean, there's huge opportunity in the industries outside of healthcare right now. I mean, you can go on an airplane, you can go on an airplane app and decide where you want to fly and which seat you want to pick, and there's an image. I think over the next 24 months or even quicker, we're going to see very similar adaptation in the healthcare industry, and it's going to be really important that we have the operational leaders, to your other question, finding where that value is and how to best meet the needs of our patients. So, I mean, it's hard. Who's doing it the best is probably not the right question, but who's actually going to be able to adapt? Which organizations are going to be nimble that will be able to apply? And I strongly believe that those organizations where you have alignment of incentives, where you have an integrated care and delivery system behind a digital front door, you're going to meet the needs of those patients because you're taking the reimbursement out of the decision making. If it's the right thing to do from a patient-centered perspective, it's going to happen, whether it be a dermatologist, an endocrinologist, or a pulmonologist looking at a patient in an ED without coming in, because the coming in gives you the opportunity to generate a bill. And this nation is going to have to solve from a regulatory and a billing perspective, where does telehealth provide value? And some of the video visits could just be a telephone call as well. We have to pair that out over the next period of time to ensure that we're using the telemedicine technology in the best ways.
Thanks. This has been a really wonderful discussion so far. Appreciate again the kind of train of thought. I know that we have lots of questions coming across. So as we continue to answer a few here, I'll be picking some from the audience and asking those. So please feel free to ask questions, everyone. The last question that I have set up here is, what are the major forces that are going to drive how you change your telehealth approach? There are payers earlier. Are there other problems that telehealth is also ultimately going to help solve? Staffing, clinical availability. It sounds like there's a number of tailwinds kind of pushing your organizations to adopt telehealth for a number of different reasons. But which ones do you think are most meaningful in how you'll change or adapt telehealth in your organization?
I mean, it's hard to understate the role of regulatory reimbursement. Like, if CMS decides they're not going to pay for video visits when the patient's in their home, the tailwinds are met with an unstoppable headwind, right? That is going to change everything immediately. And we will go back to picking and choosing which patients get video visits, which means that most of them won't, even if it's ideal. And our advocacy and policymaker education efforts will go back to begging and pleading for specific CPT codes. It's really hard to understate the role.
I'm going to give you, oh, sorry. Go ahead.
No, go ahead, Judd.
I'm going to give you a different answer. It's got nothing to do with the technology. It has to do with how our leaders lead. Richard just gave the airplane thing, and I just flew back this weekend, right? And I could book a flight, and there's a flight going at 5:00. But in all of our health systems, if you look at the volumes of ambulatory visits at 5:00 on a Monday or and 5:00 on a Friday, hey, I don't want to work Friday. There are no flights Friday. And imagine if we let every pilot decide what day they want to fly from Florida to New York or wherever they're flying from, and they could just do it. And right now in healthcare, that's more or less what we let our physicians do. Our surgeons don't do elective surgeries as much on Thursday, Friday, Saturday, or Sunday as other days of the week. And I sit around and watch COVID unfold, and I listen to all these two physician families complaining they can't be home with their kids. And I'm like, if one of you works Saturday or Sunday, the patients would be better off. The way a healthcare system is going to win or lose this technology revolution is by being available. And it's going to be about the time that people are available. And the technology can't really solve that. It can help that. But I think, you look over the years, family medicine in the last decade, their visits have fallen. I'm an ER doc. Our visits, other than COVID, are rising. My urgent care centers they're rising. Patients want availability. And so it's whoever figures out how to be available, however they are, I think is going to win.
And I think along that line, Judge, you can't underestimate or understate the importance of telehealth working with those of us who are aging clinicians, that giving us the opportunity to go to a part-time work or a per diem work. We don't want to necessarily retire. We've been doing this for 35, 50 years. And telehealth is an opportunity to continue work and meet some of those off-cycle times that people are looking for. As far as the reduction in staffing associated with telehealth, I think that's an erroneous fear more often than not. I tell my staff, you don't have to worry that we're going to replace you. We may help you retrain in another position, but we don't want to replace you. There are some natural reduction in human components associated with machine-based learning and AI, but we're not there yet. We're probably 5-10 years off from that. And our workforce will likely go down anyway, just because the baby boomers are going to age out of work. So hopefully we can move fast enough forward that we can meet the retirees coming out.
So I agree with Judd and also Carrie. I think the digital front door and the access to healthcare is going to create a 24/7 kind of convenience component that we've never really seen before. Doors don't close at 5. You can go online and get access. Our job as leaders of healthcare is to identify how best to deliver that care and make sure that it's value added. If the patient has a need, we're meeting the patient where they are. And I think Linda said it's going to change the paradigm of how we use our capital assets. For example, if a certain percentage of our visits can be handled virtually from home, we're going to need less capital investments. And hospital at home, I think, is a very promising future use of telemedicine as well. With remote home monitoring, we already send a fair amount of our elective surgical patients home. Surgical home recovery is incredibly productive. It's much more convenient for the patient. It's actually higher quality. And now we're working with Mayo to determine how do we do acute care at home using the technology in a hub strategy as well. And that will decrease the needs of hospital beds, and it changes the whole paradigm of capital investment. Much to be learned in that venue.
And a lot of fun too, Richard. You know, we created a COVID mini kit, which was basically a spirometer that was Bluetooth enabled to a app on a patient's telephone. And what we did with that during the peak of coronavirus is we had a 50% reduction in ED recidivism for COVID patients. Plus, when we combined it with a simple home DME oxygen program, we saved 4+ hospital days per patient. And these were the patients that were the sicker patients. They had to meet a risk criteria to be in the program. And it was less than $200 program to save 4+ hospital days.
We've gotten a few questions in from others, particularly around some of the technology aspects. Obviously, not everyone has Wi-Fi, and it looks like we have some responses in line. When you actually think about the technology that you're deploying in the field, whether it's telling people to use Zoom or it's using another tool, including maybe tools you're developing internally for that encounter, what are some of the best practices for the actual deployment of that technology to the field or to your providers? You talked about some of the staging and so forth, but are there any, basics as far as how you expect them to have their own setup or technology to engage with you?
Well, Wi-Fi technology works great if you have internet access. And then the secondary thing is if the patient actually remembers their password to their Wi-Fi hub, which they never do. So we use predominantly cellular-based technology, also because I have rural and frontiers that have poor Wi-Fi access. And I can tell you from a year of working this particular monitoring center, if I give a patient a tablet, they don't carry that with them all day long. If I attach it to their smartphone, they usually have it with them and they'll answer it. And so we have a lot more interactive chat from patients when we attach it to their smartphone. They'll pick up the phone if their biometrics are dropping in remote patient monitoring. We can reach them more easily. But I'm also aware that not everybody has that technology at their hands.
Thank you. Appreciate everyone's conversation. Carrie, Linda, Richard, Judd, thank you for your time today. Maria?
Oh, Maria, you're on mute.
Can you hear me now? Thank you. Thank you all very much for your time, and thank you to our audience for joining this panel discussion. We'd like to thank Nathan and our supporting sponsor, West Monroe.